patients. So now we'll just listen to Dr. Rajul on structure function correlation in Humphreys. Over to you, Rajul. Yeah, we can see your slide. Rajul, just unmute your mic. Rajul, can you unmute your mic? We can see your slide, Rajul. But,
yeah. Now okay?
Yeah.
Okay. Thanks, Satyan and AIOC for this talk. So I'll be talking about structure and function assessment and how to correlate
Timer
them.
has to be set at 6. Okay. Thank you.
So the first question is there a correlation between the location of optic nerve fiber and the visual field? And I'll be talking about perimetry because that's the machine I have, Humphrey. So there are various publications, and it is well documented that if you look here, the inferior RNFL loss, superior arcuate defect. So there is a correlation between structure and function. The second question is that does structure and function changes occur simultaneously? Now, there is a curvilinear relationship that also is documented. The threshold value on perimetry drops slowly in the early disease, and in the later on, it progresses faster. So it is a curvilinear relation, and there are lots of theory about it. I'm not going to talk about it because we don't have time. The third is that whether the structure of function changes detect simultaneously. Again, the answer is no. We have quite a few publications. If you look this patient has definite inferior RNFL loss, the wedge shape defect very clearly visible. His perimetry was normal. On other hand, the definite glaucoma, his patient perimetry showed superior arcuate, which correlated his disc changes, but the OCT was normal. So there are lots of the disc size, there are lots of parameters which plays part in the structure function correlation. We cannot go only by one. We have to correlate both. So if you look the OARD study, which had only ocular hypertension, and if you look EMGT, which had a definite glaucoma patient, the OARD study, majority of the patient had a optic disc changes on the progression, the first detected, as opposed to EMGT, which had majority of the patient showed progression on the visual field, as opposed to optic disc. And why this difference? So if you look that OARD, they had early, no optic changes on the perimetry. In the early stage, the structural changes do happen before visual field. The threshold determination of visual field testing, there's a huge variability. And if the OARD shows that nearly 85% on the test retest, the second test, they could not verify the defect which is shown on the first defect. So we must remember that as opposed to EMGT, all the patient had definite visual field defect to start with. And once the visual defect is there, the progression, as I showed in the earlier, that the curvilinear graph, the defect, the damage is picked up faster on the automated perimetry. Then the enders had developed a very sensitive visual field progression criteria, which now we are using on day-to-day practice. So that was another reason of picking up the more defect on the perimetry. The topic was that how best to correlate or how to use in clinical practice. So I thought I'll give few example. Already Manish had talked about the 24 days to see, but if you look the publication, if you look now the data Manish already showed that there are patients where we will have a definite, you can see the inferior thinning is here, but his 24 days 2 is normal. We do 10 days 2 and the points, we pick up the more points. So it is the 10 days 2 is correlating with the structure. So the Humphrey now has a new program 24 days 2C. And why? What is the advantage? The 10 days 2, we do the testing at every 2 decibel as opposed to 6 degree in 24 days 2. So when you combine, you have more points in the central area, which may pick up the glaucoma earlier than 24 days 2. And the 24 days 2, there are 10 points and incorporated in the 24, and they will name this 24 days to see. I'll just give one example. Manish has already described in great detail, so I'm not going to talk in detail. But the normal 24 days to that C is picking up the damage in the central area. So this is the one, and it correlates with the structure. So one way, use 24 days to see, especially in the early stage if the 24/2 is normal. The second, this is not available in a day-to-day practice clinically, but we have a structure function SFF. So what they had done, they had taken another different grip of 48 points. They named it DCF. and they incorporated with the 52 what we have in 24 days 2, and they combined and make it 97 unique test points. The 40 points they had was this. Each zone they had 12 points. The central area they have taken quite a few points, and the data they showed that the structure function SFF test had a much better correlation with the structure. So this is one way. Now we have forum. So how to use forum in clinical practice? The forum, it shows the disk photograph, the perimetry, and OCT and the correlation. Now the materials, they are developing a combined structure function. Like VFI we have, they are developing a combined structure function index, which will estimate the proportion of the loss of RGC compared to the amount of age-related match healthy eye. So they will use the SAP sensitivity and the OCT measurements. This is again not available clinically. Hopefully we'll have in the future. The other way, the forum to use is the structure function correlation in progression, because we know glaucoma is a progressive disease. To correlate in the progression is very important. Sometimes we may have a structure progression, sometimes we have functional progression. So this is one of my patients which had, you see, this is the GPA and this is the OCT GPA progression, and the correlation you can see that how it is correlated. This is the macula, this is RNFL, and this is how you use the structure function correlation. Ronnie is going to talk about progression in more detail, so I'll not go in detail. So to conclude, there is a great overlap between the optic nerve head parameter and RNFL in normal and early glaucoma, and because of this overlap, we do not have a perfect correlation, and we will never have. There is a large variability in automated perimetry because it's the psychophysical test. So if the patient's mood is not good, he may not do the test properly that day. We know that the current White-to-Night perimetry picks up the damage only when there are 20 to 30% ganglion cell loss already has happened. So we need to examine both structure and function, and we can use these 24 days to see the forum to prove the structure function correlation for diagnosis, for progression, and we will have certain newer parameters like the DCF in clinical practice, hopefully in future. So this is the way I would use the structure function together in my clinical practice. Thank you.
Thank you so much, Rajul, for covering up the structure function correlation. We know that one is completely a functional test and other one is a structural test. It's quite difficult. Let's hear from Dr. Angaraj also in the later part how the octopus